Hello, everyone. This is Kate Barlow. I am hosting this international mentorship program, and today we have Dr. Michael Salemi here to talk about compensatory strategies. So thank you, Mike, for coming.
Hi, good afternoon or good morning, everybody, depending on what time zone you're in. My name is Mike Salemi, like Kate said. I'm an occupational therapist here in the States. I've been an occupational therapist for coming up on my 19th year. The majority of my expertise in practice has been in inpatient rehab, both in hospitals and skilled nursing facilities, and then home health care. So actually, after people leave the hospital and leave their rehab facility and they go to return to their home and continuing therapy services in the home setting, in the home context. So thank you so much for having me. I just want to make sure that everybody's mic is muted because that's always a problem with the Zoom. So first off, the topic that we're going to be chatting about today is compensatory strategies, or sort of workaround problem-solving strategies that you can use with your population, and falls prevention. Falls prevention techniques that you can use when working with your population during occupation-based activities, or occupations, or meaningful activities, or ADLs, or whatever you want to call them. So the first thing I'd like to do is figure out how to advance my slide. Good, I just did that. I need to know who you guys, the audience, work with. I need to know what populations that you service. So can I just call on someone? Can I call on Victor first and to just give us a quick talk about what population you work with?
So I've muted everyone, so everyone needs to unmute themselves in order.
Not everybody, just the person that's talking. So just Victor. Let's see. Are you on? Hold on. I'm going to see. There you go. Go. You're unmuted now. Go ahead. Give us a talk.
Okay. Hi, everybody. I'm Victor.
Hi.
I'm from Uganda. An occupational therapist. I'm now making 4 years next year.
Congratulations.
I'm working with a number of people, cutting across right away from young children, pediatrics, and up to geriatrics. At the moment, I'm having more of geriatrics, and the falls, it's a common condition, it's a common situation that is happening among them, and a big number of them, it's due to stroke and probably spinal cord injuries, which are attributed due to the environments where they live in. In the last 3 people that I had, one was a stair, as the person was going for work, climbing the stairs, and this person ended up falling down. Another one was from a village, and she was climbing a tree to get firewood. A lady of 19 years old.
19?
Climbing, getting firewood up on a tree. And 19. And she fell and broke her back. And in fact, we've had her at our facility for the last 6 months. We just took her back home for resettlement late last month. The other one was due to the environment being a hilly place. She was walking and she fell. Also still a woman of 74 years, and she fell. Lastly, there was this one here. She was carrying luggage coming from the market, moving back home. When you try to look at Uganda, we have something interesting, which are motorcycles everywhere. We use them in here. We call them border borders. So she was from the market, and as she wanted to run away from what was coming, she ended up falling and still hurting her spine And so these are the experiences why I really got interested in being here today. Thank you.
Okay. Victor, thank you so much for sharing. You present some really unique cases where, the falls prevention that my experience has been post a diagnosis. So after someone has a non-fall related diagnosis, whether it be a stroke or a spinal cord injury or a fractured bone or a heart attack or something like that. And then during their recovery, trying to prevent falls to sort of relapse or impede their progress towards their initial diagnosis, or someone that's just elderly and maybe a little bit frail. And as our clients get older, they become they have slower reflexes and they have poor balance reactions, and they're more prone to falls. This is typically why we see elderly persons with walkers or canes. It's to prevent falling and to sort of maintain their balance. I would say that falls prevention for somebody climbing in a tree to get firewood would be, geez, don't climb in a tree to get firewood. But I know that that's probably not an option for that patient, and I'm terribly sorry that she had that experience. She had a fall. That's a good one. I didn't expect a fall from a tree as one of the first scenarios that you brought.
It's a tradition here.
So does that happen a lot?
It's a lot.
Culturally,
Traditions.
people are climbing up in trees to get firewood.
Yeah, it does. Yeah, it does, because that's the main fuel that people use for cooking.
Okay.
Especially in villages, so it's a common stuff. Yeah.
So just before we continue, they can't just take the whole tree down and then get the wood when it's on the ground?
No, you can't do that. That's deforestation.
Oh, okay. Yeah, so, we don't want to do that then.
You will get another one tomorrow. Yeah. Yeah, you want to such that when you come back tomorrow, you still get firewood,
Oh, good idea. Okay. All right. So let's hear about one more population real quick. Thank you so much, Victor, for sharing. If you wouldn't mind muting your microphone, and if somebody else could talk and just talk briefly about sort of the clients that you see and some of the deficits that you observe in your practice. What age ranges? I was going to call on Calvin, but he disappeared. All right. So I guess we'll just continue. So, obviously culture plays a big role in, oh, hello?
Hi.
Hello, are you there?
My phone tripled.
All right, I'll just continue. So, when we're looking at our clients and looking at our population and looking at the cultural aspects of how it can influence functional tasks, something like Victor's population is an excellent example where, in my culture, my clients typically don't have to climb up trees to get firewood, but in order to heat their homes. But in Victor's culture, that's in Victor's area of the world, that is obviously something that is very common practice. We have to keep that in mind. Typically, I'm going to assume that when Victor sees someone, it's not going to be, it's going to be after an injury, after a fall from a tree, like you just spoke about, and trying to combat the deficits that are as a result of that fall. You said, I think Victor said that the young lady had a spinal cord injury, and trying to help that young lady, or I forget if you said it was a man or a woman, getting back to resuming those occupations again and trying to figure out how to help that person get back to living their life and retrieving firewood. I mean, that's occupational therapy right there. May be atypical in one culture, but can be completely typical and relevant in another culture. Some of the things that I wanted to talk about today, when we think about compensatory strategies and we think about falls, is to look at the environment and look at the context. So when we think about the environment and the context, the environment is more of the physical, tangible aspects that are around our client, whereas the context is more of those intangible factors that influence occupation. So when we think about the environment and we think about physical environment, that's someone's community and their home layout, and looking at how their house is set up and where they have furniture positioned and where they might have items that can cause a problem with falls. And then we also want to think about their social environment, so their support network. If, for example, Victor's client that had the fall out of the tree, eventually after, I think he said that she was getting ready to return home, what kind of support network will she have? Well, you know what, can you tell me, it was a female, right, Victor? Can you just nod yes? Yeah, okay. That's what I thought. I don't want to, just so I can know what I'm talking about. The young lady that Victor works with, thinking about her support network, that plays a huge role in getting back to engaging in occupations, getting back to participating in meaningful activities, which are foundations of our profession, occupational therapy. We think about context, those sort of more intangible aspects. We think about cultural context, like the needing for getting firewood to heat your home. That might be something that happens very commonly in that area. We think about also the temporal context. So we're thinking about how old this person is. We're thinking about whether they're 15 or 85. We're thinking about what history they might have lived in their life. They might have been a hard laborer where they've got a lot of deterioration in their body, bone deterioration and arthritis, and a history of lots of injuries, where as they get older, it makes it much more challenging to engage in occupations and meaningful activities. Whereas in contrast, if it's a younger person, they might have had, they're going to obviously have less wear and tear on their body. And also just thinking, when we think about temporal context, just thinking about the time of day that we're doing activities. Maybe if, just again, to use Victor's example, if somebody was climbing up in a tree in the middle of the day when it's 2 o'clock and the sun is beating down and they're getting sweaty and they're getting tired from climbing up and down and getting firewood, that's going to make that task much more challenging than maybe if they did it first thing in the morning at like 6 o'clock in the morning, 7 o'clock in the morning, when the sun is first coming up and it might be a little bit cooler and they might be able to tolerate that activity more. So if we combined all those aspects into thinking about the occupation of having to retrieve firewood from a tree, and thinking about the cultural context of the need to do that, and then the temporal aspects of having a younger person versus an older person and what time of day they're doing it, you can see how, as we think about these things, they're all, some of them are in our control as occupational therapists, and some of them are completely out of our control. And we just have to try and manipulate what we can to help maximize engagement into the activities for our clients. And then finally, thinking about the personal context, which would include the person's education level or their demographic, and which might impact their safety awareness. If someone has a lower education level, they might be less likely to engage in safer activities and might take more risks. So these are all things that we need to think about when we're trying to develop plans for compensatory strategies for our clients. So when we think about occupational engagement, and we think about somebody that has had a disconnection due to an injury, say from a spinal cord injury, that is obviously the loss of motor and sensory function is going to have a significant impact on engaging in meaningful activities and occupations and ADLs and in those tasks that we think about. But there's lots of different barriers that can exist and get in our clients' way and stifle them from being able to participate in those meaningful activities. One is just pain. So, somebody that's older, and again, it might have some deterioration in their body, whether it's arthritis or history of injuries, might tend to have more pain. And so when we get pain, that can directly result to a withdrawal from maybe the physical or the emotional ability to engage in an activity that can be strenuous but yet meaningful. We can find that the typical sort of Western mindset to manage pain is to give medications, but there's I'm not a big fan of that. And one big thing that we can use is just distraction. I'm going to tell you a quick story of a young lady that I worked with. Okay. So her name was Ethel. She was 75 years old. She had gotten into a car accident and she had had some fractures, but they were rib and pelvic fractures. So from a mobility standpoint, she had a pretty quick recovery. After her accident, she was full weight bearing everywhere, and she was able to, she had no restrictions to movement. But she had some cardiac complications. So Ethel started to have congestive heart failure and build up fluid. And so it really just weakened her a lot. And she could not tolerate much activity. But she had to get home to help take care of her husband, who was much more frail than she was. So Ethel, we bring her down to therapy. We're working with her on a daily basis, and she cannot stand for more than 2 minutes during an activity because of pain. Okay, she has problems with pain, and she gets problems with fatigue and anxiety. So if we do any kind of activity, after about 2 minutes, she needs to sit down. She just has to sit down. So what we did was we identified a meaningful activity for her. So we found out that she was renowned in her family for making pies, okay? Apple pies. Ethel's apple pies were supposed to be like the best in the area. And we found out that she loved to make them from scratch. So we brought Ethel into the kitchen that we had, and we said, Ethel, we're going to make some pie today. Can you show us how to do it? And the first time, she stood for 20 minutes without complaining because she was engaged in a meaningful activity and she was distracted, okay? So the power of distraction can be really incredible. We took an activity that was familiar to her, that was important to her, and we used that as a diversion or a distraction to help her make progress and be able to become more confident in her own abilities. Does that make sense? So again, using the power of meaningful activities and the power of occupations for diversion and distraction to get back to normal performance patterns can be really powerful. And whenever she sat down and she said, boy, I'm exhausted, I said, you stood for 20 minutes and you only were able to stand for 2 minutes over the past week and a half in therapy, because she would have never, I can't say that she would have never made progress, but she really needed to be able to stand for a lot longer than 2 minutes in order to get back home and resume those roles of caregiver for her husband and taking care of her house. So distraction, that's a big one. So when we think about some of the other issues that can come about, we can have our clients that have pulmonary or breathing issues. And when they have breathing problems and they can't tolerate as much activity, that's going to reduce their ability to tolerate activity and thinking about how we modify those. We'll talk about that in a minute, how we modify those activities to reduce the exertion that happens during any particular occupation in order to get them to resume it. Just like using Ethel's example, if she had chronic pulmonary lung disease or something where it was making it difficult for her to tolerate any sort of exertion, if we modify the task and have her sit down instead of stand up, it's going to be way less taxing on her. And henceforth, it's going to be much easier for her to participate in that task. When we think about barriers for occupational engagement in our cardiac population, so heart attack, heart surgery, these types of things, we want to be very mindful of blood pressures and heart rates. When we're working with our clients, and also trying to empower them and teach them about being aware of their own blood pressure and their own heart rate. One thing when we think about falls prevention is we can see folks as they get older, or they have cardiac issues, if they have hypotension, low blood pressure, that can cause lightheadedness. And lightheadedness and dizziness can cause falls. They're directly related. So if we teach our clients to be mindful of their blood pressure and their heart rate, and if their heart rate gets too high, then maybe that means their blood pressure is getting too low, and they might need to stop and take a break for a minute. They might need to drink some water because they're getting dehydrated or something. But just being mindful of our cardiac population and having them be aware of their blood pressure and their heart rate is really important. And then we've got, of course, the neurological population. This is always the most complicated of the populations, which I'm sure many of you know. As we go on to the next slide, when we think about our neurological population, there can be just so many deficits. And depending on what the diagnosis is, whether it's brain injury or stroke or spinal cord injury or peripheral nerve injury even, there can be so many different issues that impact occupational engagement. So if we've got somebody that's got any sort of brain involvement, whether it's stroke or traumatic brain injury, we're going to see an issue with poor safety awareness and the inability or diminished ability for our clients to recognize what is safe and what is unsafe, and being able to recognize where their deficits are. We know that when we work with our spinal cord, our brain injured and stroke population, they can definitely have significant problems with insight. And insight is being able to recognize one's deficits and thinking they can do things that they can't do. Think about the client that we have that has a stroke and maybe has neglect from that stroke and doesn't realize that their right leg cannot hold them up, yet they still try to stand and walk and go to the bathroom and get around their house. And this is going to cause lots of falls. So just being mindful of safety awareness and decreased insight into one's deficits. Obviously, when we get into the brain injured and spinal and stroke population, we can see issues with decreased body awareness, with neglect of one side and not being aware of one side of one's body, or not being aware that one side of the body is not working the way it should be and not functioning normally. We can see problems with balance and vestibular function from these diagnoses, and we can see people that can have falls just from that. And they might have perfect safety awareness, and they might know exactly where their problems are, but they might have problems with their ability to balance and keep their center of gravity over their feet when they're walking from brain involvement. And then when we see also with this population, we might see lots of issues with emotional changes and instability and hyper responses to normal situations, and not being able to have good control of one's anger and one's emotions, and like I said, having hyperactive responses, emotional responses. And then of course, the typical biomechanical issues that we see, which are decreased strength and range of motion, and the decreased sensation, which directly feeds into the neglect. So as OTs, hold on, I'm just going to take a little sip of the coffee here. So as OTs, what strategies can we use to use our skill set to have a positive health impact on these folks, these clients that have deficits and inabilities to engage in their occupations. We have to just take a step back and get back to our foundational mindset of identifying an activity that we want to accomplish, identifying the barrier that is in the way of safe participation. For Victor's client, who is a young lady with a spinal cord injury, she might not have the ability to climb up in a tree and get firewood again after her injury if her deficits are permanent. But that might be something that's really important to her, and that makes that a meaningful activity. That makes that something that, as she's able to resume that activity, then that's going to have a profound emotional impact, positive emotional impact. And trying to use a trial and error method. Think of maybe some, give her some strategies that she might be able to use to resume doing those activities, or involving herself in different aspects of the task. Maybe she might not be able to climb up a tree and cut branches off of a tree to use for firewood, but once the branches are on the ground, she might be able to gather those up on her lap if she's in a wheelchair and bring them around, or help organize them or something, and just getting her involved in other aspects of that task. Like I said, with trial and error, don't be afraid to use the trial and error method. Don't be afraid to make mistakes, because not every compensatory strategy that you think of is going to be a home run, and that's fine. Don't be afraid to make mistakes. Obviously, you don't want to make mistakes that can affect the safety of our client. But trying different techniques with anything, or having someone resume different parts of an activity, maybe it's not going to work the way you envisioned it, and have a plan B or a plan C, grading the activity like we learned in OT school. But just don't be afraid to make mistakes is what I'm saying. And like I mentioned a minute ago, just making sure that the task that we're trying to have our client engage in is a meaningful task, something that's important to them, like the firewood for Victor's client, or apple pie for Ethel. Making apple pies for Ethel was a very meaningful activity. And when we're trying to get our client back to engaging in that activity, making sure that the modifications that we're trying to implement are that the task is achievable with those modifications. Okay. So when we think about reducing, facilitating safe engagement in occupations, we obviously want to reduce the potential to have a fall. So when we think about this, we want to think about that temporal context, and maybe performing tasks at the best time of day. Maybe someone is can be sort of a negative situation, but maybe someone's an alcoholic, right? And we know that every day around noontime they start drinking. So then at 5 o'clock at night would not be the time when they're intoxicated to engage in activities that we want to work on. Maybe we want to work on those first thing in the morning, or maybe we know that there's a certain medication that our patient with that has had a heart attack, we know that there's a medication that they take in the afternoon that makes them a little bit dizzy as a side effect, and we want to make sure that they do that task in the morning. So just identifying the best time of day to perform tasks, like the example of the tree, and not climbing up in the tree in the middle of the day when it's hot, and maybe doing that first thing in the morning to reduce the exertion that happens. As occupational therapists, we always want to try and anticipate every hazard that could get in the way, and every safety consideration that we can think of. And then finally, when we are working on getting our clients back to working on participating in those occupations that were, if they are standing, that we're thinking about their stability with standing. So say, for example, Victor's young lady when maybe she has a recovery where she's able to start standing again, but she has balance issues, but yet she wants to get back to sawing firewood. Maybe she wants to do that standing up. Well, maybe she needs to lean on a stool or lean on a branch or lean on something in order to maintain her balance while she's doing that. So just thinking about stability when we're in standing activities in order to not have a fall. Okay, just gotta move this over here. Also, when we're thinking about getting back to safe engagement in occupations, we think about simplifying a task, so breaking a task down. If we think about Ethel, who is making her apple pie, like we might not be able to just put her in the kitchen and say, okay, go make an apple pie, because maybe she can't stand and doesn't have the balance enough to put it in the oven, or maybe she doesn't have the strength in her arm to open the refrigerator, or maybe she gets dizzy when she stands up, who knows what. But trying to at least develop or give her opportunities to participate in simplified steps in that task and modifying that task. Obviously, we talked about making sure that the task is meaningful to the client, but also thinking about the person's prior level of function. So what did they do beforehand? So if Victor's situation, if that young lady that had the fall, maybe that was her first time she ever climbed up in a tree, and she didn't, and maybe she's had a full recovery from her deficits and now she's able to walk again. But maybe that time that she fell from the tree was the first time she ever climbed up in the tree. Is it really, maybe it's not an achievable goal for her to go back and try and start climbing up a tree to do firewood again, because it wasn't in alignment with her prior level of function. If, maybe if I've got a client that, I'm seeing in home care and I go out to their home and they haven't mowed their lawn in 15 years, that's not going to be a realistic goal for them to resume mowing their lawn or resume taking their trash to the street now, because it wasn't in line with their prior level of function. So getting back to OT basics and remembering that we're considering the prior level of function, how they were doing before this injury, in order to make sure that we're developing achievable goals. And then finally, when we think about our clients with chronic conditions, so whether it's chronic pain or chronic lung disease or chronic heart disease or maybe a stroke that happened 15 years ago, always trying, and you're seeing them for the first time, always try and advocate for them to try new strategies and try new tricks, because when we see people with chronic conditions, they get sort of in a rut and they just tend to do things the way they do things. And it might not be, they might have the potential to do more and do bigger things and do even more meaningful activities. Maybe somebody wasn't able to, they've got some breathing issues and they can't tolerate gardening, but gardening would be something that would be really therapeutic for them. And getting back into that might help with their emotional state if they've got issues with depression from their chronic conditions, okay? So when we think about falls prevention with occupational engagement, rule number 1, don't climb in a tree. Rule number 2, we think about in the home. So we're thinking about in the client's physical environment, removing trip hazards and reducing clutter that might be in the home near walkways. If there's animals in the house, trying to make sure that the animals aren't running around or running near the client when the client's up and walking around. If the person has breathing or cardiac issues that we're teaching them to have their assistive device, if they have an assistive device, before they get up and walk around, or maybe when they're going to get up out of bed to sit up and wait for 10 seconds before they stand up and go, because they might have a drop in blood pressure when they're having when they first get up out of bed or when they first get up out of their chair. Making sure, if possible, that we're giving our clients are having adequate lighting and they're not trying to get up in a really dark room where we have to remember that our vision plays a big role in our balance, and the input and what we see and in our area in space can affect our ability to figure out where our body is in space, and that has a huge impact on someone's ability to balance. Encouraging our clients to exercise and maintain flexibility. With range of motion and strength comes balance. When we think about our clients are going into the bathroom, the bathroom can be one of the more dangerous rooms in the home. And if it's possible to have bars on the wall, installing bars, or even just using something as low tech as having a chair around and just using the back of the chair such as a handle of a walker, just to use that for balance, to stand up in the bathroom, to use it for stability. And when we think about falls prevention for occupational engagement, trying to make the items that someone might need most commonly a little bit more accessible. One trick that I used frequently was in the refrigerator. In this neck of the woods, everybody always keeps the things they use the least on the door of their refrigerator. Yet the door of the refrigerator is the easiest place to get at in the entire refrigerator. When you open the door, it's all right there. Yet when people tend to take their most commonly used item, put them on the top shelf of their refrigerator in the back. And so there's a lot of bending and twisting that happens. So it's less accessible. If someone has a cup of coffee every day, having their coffee mugs easy to access and on a lower shelf so they're not reaching and stretching, or not all keeping their coffee mugs all the way down, say on the bottom shelf or on a bottom cabinet, so they have to bend down and twist. Just having easy access to commonly used items can make a big difference. And then just providing strategies, teach your clients to put their hand in a certain spot for balance, instead of just coming up with safe strategies for our clients. So I'd like to, if we've got anybody else that's here besides Victor, that would like to talk about an issue that they're having with a client, and see if we can have a dialogue to problem solve any issues that they might be having with any challenging cases. Is anybody here that would like to talk besides Kate and myself and Victor? I guess that's a big no. All right. Well, like I shared one example with Ethel, with her making her apple pies and using that as a means oh, hello.
Okay. Hi, everyone.
Hi.
I'm still trying to get used to the Zoom app. Yeah. Okay. I actually clicked on raising hand, but I'm not sure you saw that. I'm Israel from Nigeria. I'm an occupational therapist. And I am so excited because I finally got to join you guys today. Yeah, I've been trying to join the meetings.
It's good to have you here.
Yeah, thank you very much. And I would really love to say it's wonderful to hear you go through the slides and talk about how we as occupational therapists could, work with patients and to prevent them from these falls. I would really love to say you've done a lot, Michael. And I would say thank you very much.
Anytime.
Thank you very much. Yeah, I currently work with kids. I work in a pediatric setting.
Mm-hmm.
So I think this will also be practical for kids who have hemiplegia or hemiparesis currently.
So do you have, what was your name?
Israel.
Hi, Israel.
Is my name.
So hi, Israel. Sorry, I missed it in the beginning. So do you have any particular cases that you have right now, or you had recently, and you want to share your experience, or maybe that you're having a hard time figuring out the best choices to make, and we can see if we can figure it out as a group?
Currently, no. But like I said, I think I could put this into practice with children that are currently having hemiparesis or hemiplegia. Yeah. So I think I could also work with the slides you've already given to also put that into practice and preventing them from falling during therapy sessions, and teaching the parents and people at home some home modifications they could also do for them too. I think it's gonna be very helpful for children with hemiplegia. Yeah.
Well, I'm glad to hear that.
Thank you very
And
much.
if you ever have any further questions after today, you can always reach out to Kate, and she knows how to get a hold of me, and I'd be more than willing to talk to you at any time.
All right. Is it possible to get the recording of this? Like maybe the recording of your voice while you were explaining the slides. Is it possible to get that?
Yeah, Kate will be sending out a recording of this presentation at the end, and it'll be just a clickable link, and you'll be able to
Hear the voice cover.
hear the voiceover for all the slides.
Oh, thank you very much, Michael.
No
I
problem.
usually send it out about 2 days later.
Okay. That's fine.
Well, I want to talk briefly, while we have an extra minute, of a young lady that I know that had a spinal cord injury.
Okay.
And, when we think about the spinal cord, somebody after a spinal cord injury, when she was 20 years old when she had a fall and was T7, which is mid-abdomen and complete paralysis from the abdomen down, and that was 10 years ago, and she never walked again. And she is a wheelchair user now, but even recently, she just in the last year, before her injury, it was really important for her to ride horses. She loved riding horses, right? So then she has this injury, and then after that, she was not able to ride horses. She was just trying to figure out how to live life as a new wheelchair user in a world that is predominantly not wheelchair accessible, and just trying to be a 21-year-old girl who now has a completely different life in front of her. And just recently in the last year, she was able to get back on a horse again, with some minimal modifications, and ride a horse. And it had a profound emotional impact on her, more than she ever anticipated. So when we think about our clients, and we want to always think about not only the apparent deficits, but also those sort of less visible deficits of mental health, and not only acutely, right after their onset of their injury, but also chronically, 5, 10, 15, 20, 30 years later, we can still be having, as occupational therapists, having a positive impact on our clients. Imagine, Victor's young lady that sustained the spinal cord injury. She's going through a really traumatic emotional process right now of probably, there's lots of different emotional stages. There's denial, there's anger. At one point or another, or maybe not, she'll accept the fact that she has this new life ahead of her. But 10 years from now, if she runs across Victor again and Victor says, "Hey, you know what? I thought of a really great way that we could just use a little rope and a piece of wood, and you could shimmy your butt right up in the tree and start cutting down branches again, just like you did 10 years ago, and you're going to get back to doing that." And think about the emotional impact that would have for her to be able to do something that she hadn't done since her injury. So, just thinking about the difference that we can make, not only in the acute stages of diagnoses, but long-term, and that we can always, anybody that has any issues with an inability or a barrier to engaging in occupations and meaningful activities, that's our skill set, is to be able to help those clients get back to participate, however we have to do it. and at whatever problem solving we have to use. So yeah, Victor, are you waving to me or you want to say something? Go ahead. The floor is yours. You just got to make sure you unmute. There you go. You're good.
Okay, thank you. Yeah, I was saying, thank you so much, but I have a few issues that I would love to see how I
That's
can
great.
further help my client. She is a tailor by profession, and during the process of her treatment, she expresses this case that, I want to continue with my tailoring, because at first we tried introducing in different activities that she can make use of using her hands. The injury she got is Asia A, and according to assessment, there is no possibility of walking again, meaning she's going to be a wheelchair user. I don't know for how long, but we do not see a possibility of her walking again. So and she's interested in doing tailoring.
Yeah, what level of injury is she?
Asia A.
Yeah, what level? On the back? Where does her paralysis start?
From the waist downwards.
Okay, so she has full use of her hands.
So the hands, the upper extremities. Sorry. Yeah, the upper extremities are all okay. She can use them easily, and she can sit in the wheelchair and ride herself. We also try to make use more of her hands than the legs. So among the activities we're looking at, probably, I don't know whether you can look at this. You see this?
Yeah.
Yeah, it's a bag, using beads and all that. So we had different kind of activities that we were trying to introduce to her. But after everything, she zeroes down to one thing: I want to continue with my tailoring because that's what I went to school to do. So we had to look at, what do we do? Can we get some tailoring machine that someone can operate only using the hands,
like a sewing machine, right?
We succeeded. Yeah, a sewing machine, and we succeeded in doing that, but still, I don't know whether the quality or what, but she couldn't use it so well because she says it's faster than than what she can do. She needed her legs as well, but slowly we are overcoming that slowly. But now there are two major issues that she still has. That even when she's seated in the wheelchair, she gets this trauma: I may fall. So it's hard for her to spend a lot of time seated in her chair. And then two, she has a difficulty of stigma. When she looks at people walking, so she's becoming suicidal, thinking, oh, you mean I'm not going to walk again? And I remember there are times when she told me, I think if I could walk, I would walk from my bed, go to maybe a pharmacy or somewhere and buy some medication or poison and kill myself. So she's having that ideation. And when you ask her, why would you want to do that? She'll tell you, because I'm not going to walk again, so I don't see a reason of living and all that. So two issues that I really see, and how do we as OTs come to help?
So, the emotional changes that we see in the spinal cord injured population, especially the younger spinal cord injured clients that have, they had a vision of an entire life in their heads. And that in one instance, the entire path that they had envisioned for themselves is changed permanently. And there used to be, the older mindset was that there was a hierarchy and there were stages of the emotional changes. And then it went from denial to anger to depression, and then finally acceptance. But now sort of more modern thought processes, or that people go in and out of different stages in no particular order. But one thing that we see in this type of population is to help with emotional processing is not a support group, but maybe just a peer, maybe just trying to get that young lady plugged in with someone else that's had a spinal cord injury, maybe that's been living with it for a little bit longer and maybe has learned how to be much more independent. So, I don't know if there's a way that you could identify somebody else in your community that maybe had a spinal cord injury 10 years ago and they've been living, now they've resumed maybe driving or working or anything like that, and trying to, show your client that, even though you might not have the ability to walk again, but you do have the ability to live again. And, showing them that that can having a peer or a support network of some nature can really have a positive emotional impact on a client. And sometimes initially it can have a negative impact where, you got somebody that really believes that they're going to walk again, and then they see people that have had spinal cord injuries for 10 years and they say, oh, these people never walked again. Maybe I'm really never going to walk again. And that can initially have a negative impact, but, really in the long term, it can have a positive impact because it can help them see that they are able to live again. When to answer the first part of your question and talking about getting back to sewing and tailoring, and that she feels that the machine is too fast, and she feels that she has a hard time stabilizing herself. You could try taking a look at what her body positioning is and making sure that she's in a good she has good support in her legs and she has good support in her butt. In our spinal cord injured population, positioning in the wheelchair and how someone's pelvis is positioned can have a huge impact on their upper body stability. So proximal stability equals distal mobility, right? So if we're stable in our core, then we're more mobile out in our extremities. And maybe just taking a look at how her body position is and sitting in when she sits at the sewing machine, and looking at ways that you could possibly give her some stability at the elbows. So, if she's not able to use her core muscles to sit and balance, she might be able to use her elbows to help balance, or at least one elbow down on a hard surface while she's able to do some of the tasks of tailoring with her other hand. Again, like I said earlier, just using the trial and error method and just trying different things. And, you might suggest that one thing is going to work and it doesn't work. And just say, listen, let's try something else. And, in this day and age, Google is, and the internet is a profound resource. And, if you Google using a sewing machine with a spinal cord injury, I'm sure somebody's got a website somewhere in the world that has something to do with that. And, trying not to reinvent the wheel and use someone else's ideas can work. So, I'll be curious to see how I hope you get my email from Kate and let me know how it works out with modifying that. And I hope that she gets back to sewing again, because that would be huge for her, a meaningful activity.
Yeah.
That's what it's all about. All right, so we're almost at 3:00 here. Kate's back and with her Christmas decorations behind her. Does anybody have any other questions? No, I think maybe we're good. All right, I'm just trying to figure out how to make the Zoom big again. Okay.
This was great, Mike. Thank you so much. I did change rooms because my boys are home, so I'm hiding in one of their bedrooms.
I can see that. Well, it was really nice to spend some time with everybody that's here. And if anybody has any further questions, just email Kate, and she knows how to get a hold of me. She only lives about 5 minutes away from me, so.
All right, well, thank you so much. And if you all just have 1 minute,